Central Nervous System Tuberculosis Part 1. Presented by Dr. Jalal Mohsin Uddin. DTCD, FCPS Pulmonology. Associate Professor, NIDCH. Introduction. Central Nervous System Tuberculosis (CNSTB) is a severe form of tuberculosis affecting the brain, spinal cord, or meninges, with common presentations including tuberculous meningitis (TBM), intracranial tuberculosis, and spinal arachnoiditis. Tuberculous meningitis (TBM) is a severe, potentially fatal form of extrapulmonary tuberculosis (TB) that inflames the membranes surrounding the brain and spinal cord, caused by Mycobacterium tuberculosis. Epidemiology. Around 25% to 30% of the human population is infected with MTB. CNSTB is reported in 1% to 2% of individuals with active tuberculosis. CNSTB accounts for 5% to 8% of extrapulmonary tuberculosis (EPTB) cases in immunocompetent hosts. Approximately 70% to 80% of CNSTB cases present as TBM. Tuberculosis are seen mostly in Indian subcontinent and parts of Asia and may account for 20% to 30% of all intracranial space-occupying lesions. Epidemiology. Despite the diagnostic and treatment advances, CNS TB still carries a mortality rate of 15% to 40%, especially in children. TB meningitis is more likely to occur in children. Approximately one-third of patients with TB meningitis have disseminated disease. Classification of CNS TB. Intracranial tuberculosis, tubercular meningitis, patchy meningitis, granulomatous basal meningitis, parenchymal tuberculosis, tuberculomas, tubercular abscess, miliary tuberculosis, focal tubercular cerebritis, tubercular encephalopathy, tubercular hypophysitis, tuberculoma and plaque, spinal tuberculosis, tubercular spondylitis Pott's spine, spinal tuberculosis, tubercular arachnoiditis with myeloradiculopathy, tubercular myelitis, others, orbital tuberculosis, tubercular otitis media and temporal bone tuberculosis, tuberculosis of calvarium and skull base. Risk factors. Predisposing conditions include mainly immunosuppressive conditions, untreated HIV infection, long-term corticosteroid therapy, alcoholism, substance abuse, head trauma, diabetes mellitus, malnutrition, recent exposure to active tuberculosis, history of taking immunosuppressive drug, recent measles infection in children. Pathophysiology. 3 CNS-TB forms develop by different mechanisms. Tuberculous meningitis. CNS-TB may arise from hematogenous MTB dissemination following a primary lung infection, pulmonary tuberculosis, or late disease reactivation. Meningeal or ependymal seeding results from this spread, forming multiple small granulomatous foci or tubercles-rich foci that may proliferate, coalesce, caseate, and rupture into the subarachnoid space before the onset of meningitis. Pathophysiology. Free bacilli produce an intense, cytokine-mediated host inflammatory response, leading to the following: leptomeningitis, ependymitis, choroid plexitis, encephalitis, and patchy meningitis with basal and opticochiasmatic arachnoiditis (OCA), vasculitis with endarteritis and infarcts. Hydrocephalus secondary to disturbed CSF flow and absorption. Terminology. Leptomeningitis is the inflammation of the pia mater and arachnoid mater. Ependymitis is the inflammation of the ependyma, the lining of the brain's ventricles and choroid plexus. Patchy meningitis is an inflammatory condition of the tough outermost membrane surrounding the brain and spinal cord. Pathophysiology. The extensive exudative arachnoiditis at the brain's base and the optic chiasma entraps multiple cranial nerves in the area, including the abducens, optic, oculomotor, and trochlear. Arteritis and phlebitis result in vasculitic infarcts due to arterial vasospasm, thrombosis, or hemorrhage. Inflammation can spread to the basal cisterns in many patients, disrupting CSF circulation and absorption and producing communicating hydrocephalus. Obstructive hydrocephalus occurs, though rarely, due to ependymitis-induced narrowing of the cerebral aqueduct or compression by brainstem tuberculoma in the fourth ventricle. Terminology. Communicating hydrocephalus is a condition where cerebrospinal fluid CSF cannot be absorbed properly after it leaves the brain's ventricles, even though it can still flow between the ventricles. Pathophysiology. 2. Tuberculoma. Deep-seated tubercular granulomatous foci acquired during initial bacteremia may coalesce and develop into conglomerate caseous masses called tuberculomas without producing meningitis. Often, tuberculomas may be present as clinically silent single or multiple lesions in patients with TBM and detected on brain imaging. Patients' MRI showing multiple hypointense, nodular lesions ranging in size from 5 to 9 mm were observed on T1WA, T2WB, and FLAIR-C images, showing infratentorial and supratentorial distribution with partial preservation of the central parts. There was surrounding vasogenic edema, which was observed as a patchy signal increase on T2 and FLAIR images B, C. Pathophysiology. Tuberculomas may form tubercular abscesses in immunosuppressed individuals. It is a serious condition that can be difficult to diagnose because its symptoms and imaging results, such as headaches, focal neurological signs, and raised intracranial pressure, can mimic those of a common pyogenic brain abscess. Tuberculous brain abscess. Axial post-contrast CT image showing a well-defined rounded peripherally enhancing lesion with hypodense center and associated perifocal edema in the left temporoparietal brain. B. Axial post-contrast CT image showing gliosis in the left temporoparietal brain and resolution of the perifocal edema following surgery and antituberculous therapy for 2 years. Pathophysiology. Spinal cord tuberculoma may form at any cord level through similar mechanism or by local extension from nearby tubercular spondylitis. They are rare compared to intracranial tuberculomas and can be challenging to diagnose, particularly in individuals who are not from endemic areas. Epidemiology. Only 0.2% of central nervous system tuberculosis shows evidence of spinal cord involvement, and among tuberculosis patients, the incidence is only 2/100,000. Magnetic resonance imaging of the lumbosacral region revealed an intramedullary lesion of heterogeneous signal intensity on T2 weighted images at the level of conus medullaris with cord expansion and edema. Pathophysiology. 3. Spinal arachnoiditis is a rare, chronic inflammation of the arachnoid membrane that surrounds the spinal cord, causing scar tissue and nerve root clumping, paralysis, and vision loss. Symptoms may include chronic back pain, radiating pain, numbness, or tingling in the legs, weakness or paralysis in the lower limbs, urinary or bowel incontinence, sensory changes, such as loss of temperature sensation, aerosol transmission of MTB, B. Phagocytosis of MTB by alveolar macrophages inside alveoli. C. Granuloma formation in the lung. 90% of hosts with granulomas maintain them stably over the course of their lives. D. MTB escapes from the granuloma, which occurs in 10% of latent TB patients. EMTB can cause TBM by escalating from the lung or by secondary reactivation from a leaked granuloma, which is then filtered into a regional lymph node. After spreading through the blood circulation, MTB can enter the CNS through the BBB, likely by a Trojan horse mechanism. G. bacilli seed to the meninges or the brain parenchyma, forming subpial or subependymal primary complexes. Symptoms and signs. Signs of central nervous system CNS tuberculosis TB often start gradually with nonspecific symptoms and can progress to severe neurological issues. The signs vary depending on the area of the CNS affected, such as the brain membranes tuberculous meningitis or the formation of tissue masses tuberculomas. Frequency of symptoms and signs, clinical features. Frequency. Presenting symptoms. Headache, 50 to 80%. Anorexia, 60 to 80%. Emesis, 30 to 60%. Photophobia, 5 to 10%. Physical exam findings. Fever, 60 to 95%. Neck stiffness, 40 to 80%. Confusion, 10 to 30%. Coma, 30 to 60%. Cranial nerve palsy, 30 to 50%. Hemiparesis, 10 to 20%. Paraparesis, 5 to 10%. Seizures in adults, 5%. Prodrome phase of tuberculous meningitis. These signs can last for several weeks and include low-grade fever, persistent or intermittent headache, malaise, fatigue, or general feeling of being unwell, personality changes or confusion, night sweats and chills, loss of appetite and weight loss. Signs of tuberculous meningitis TBM. As TBM develops, inflammation of the brain membranes leads to more distinct neurological signs, stiff neck meningismus. A hallmark sign of meningitis, though less common in young children and the elderly. Specific clinical tests, like Kernig's sign and Brudzinski's sign, can also be used to check for this condition. Meningeal signs. Assessment of nuchal rigidity. Passive neck flexion chin to chest elicits pain or resistance. At the same time, check the rotation and lateroflexion to differentiate local cervical pathology. Kernig's sign. In a supine position, flex the hip and knee to 90, then attempt knee extension while keeping the hip flexed. Meningeal signs. Resistance to knee extension or pain along the spine or hamstring indicates irritation of the meninges or spinal nerve roots. Brudzinski's sign. Passive neck flexion causes reflex knee flexion in the supine position. Signs of tuberculous meningitis TBM. Worsening headaches. Headaches become more severe and protracted. Vomiting and nausea. Projectile vomiting can occur without warning. Sensitivity to light. Photophobia, a common symptom of meningitis. Mental status changes, can range from confusion and lethargy to stupor and coma in later stages. Signs of tuberculous meningitis TBM. Cranial nerve palsies. Damage to the nerves can cause facial weakness, eye movement issues affecting cranial nerves 3, 4, and 6, and hearing problems. Seizures can occur due to irritation from the inflamed meninges. Hydrocephalus, the buildup of cerebrospinal fluid CSF can lead to increased pressure in the brain, causing severe headache and other neurological symptoms. Symptoms and signs according to phase. Symptoms are often insidious and can be divided into stages. Early stage or prodromal phase 2 to 3 weeks. Low-grade fever, general feeling of being unwell, headache, irritability, and loss of appetite. Late stage or meningitis phase. Worsening headache, neck stiffness, aversion to bright lights. Photophobia, vomiting, confusion, seizures, and cranial nerve damage. Advanced stage or paralytic phase. Drowsiness, paralysis, hemiplegia, and coma, leading to death if left untreated. Signs of tuberculosis. Tuberculosis are tumor-like masses that form in the brain or spinal cord. Signs depend on their size and location. Headaches. Seizures. Focal neurological deficits, weakness or paralysis on one side of the body, hemiparesis, aphasia, speech problems, or vision issues, depending on the mass's location. Increased intracranial pressure can cause headache, papilledema, optic disc swelling, and changes in consciousness. Signs in infants and children. Symptoms can be more subtle in young children. Poor feeding. Irritability or extreme lethargy. High-pitched crying. Fever and poor weight gain. Seizures. Bulging of fontanelle. Thank you all. Tuberculosis. Central nervous system tuberculosis Part 1. Learning pulmonology.